Hello and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being here today. This is March 28th, 2018 for our UNC Cancer Network Medical and Surgical Oncology Lecture. Just a few preliminaries before we meet our guests today. We do have a website. It's unccn.org. You can find a ton of information there, including all of our past lectures. I think we're up to over 200 now, as well as information about all sorts of lectures coming up. If you're experiencing any technical difficulties right now, please call us, 919-445-1000. Don't sit there and let any problems continue. Call us. We have folks standing by who can give you all sorts of information about ways to correct any problems that may be occurring. We're on Facebook, we're on YouTube, but we're on Twitter, so find us all of those places. With that in mind, let's go ahead and move forward. And I do want to let you know that we will be using Poll Everywhere today. We have a poll at the beginning, and then you'll have an opportunity to share your questions with our presenter at the end. So if you would take just a moment to go ahead and log into Poll Everywhere right now, and you can do that from any phone with texting capabilities. You just go in the to field and type in the number 22333. So in the to field, and you can follow along with me right now, type in 22333. In the message field, you'll put in UNCCN, again, UNCCN in the message field, and you send that, you'll get a little reply back that says joined, and now you are ready to go for the polling. You can also go to pollev.com/UNCCN if you want to just go through a web browser, but most of our participants join via the texting method for that. So once you're there, you can look at our poll, which I've got up on the screen here now. According to the American Cancer Society, the cancer that occurs most often in children is, and if you believe that's brain and spinal cord tumors, you're going to put in A. If you believe that's kidney cancer, B. If you believe that's leukemia, C, and lymphomas, D. So A, B, C, or D. This is anonymous. You won't be graded, so please take a moment to do this. And then you'll be all joined in and ready when you share your questions, and we hope you'll be thinking about questions and then sharing those with our presenter at the end. All right. So without further ado here, I want to welcome Dr. Thomas Alexander. Thank you so much for being here with us today.
Great to be here.
Good, good. Well, let's see. We've got a few things to tell our audience about you. Your clinical passion is for caring for patients with hematological malignancies, focusing on high-risk refractory and relapsed leukemia and lymphoma. His areas of research focus include genomics of acute leukemia and early-phase clinical trials. He led an international effort to characterize the genomics of a high-risk subtype of leukemia called mixed phenotype acute leukemia and remains involved through the Children's Oncology Group at St. Jude Children's Research Hospital to study biology of this rare type of leukemia. He is leading efforts at UNC to expand clinical trial opportunities for children and adolescents with relapsed refractory malignancy. Wow, it's an impressive overview there.
Thank you. It feels like it's been a lot of work, but I think one thing I'll try to emphasize today is how many people are involved in every bit of this work. And I think for the people who are healthcare providers, that's not news, but I think especially for children, the number of people that provide support continues to astound me. So that's one of the things I'll hopefully get across today.
Great, thank you. And just very briefly, I mean, did you know you wanted to be a hematologist at age 5, or is that something that evolved down the road? What led to your interest in your field?
I actually was a little bit of a late bloomer. I didn't consider medicine until midway through college, and then I didn't consider oncology or hematology until midway through residency. Okay. So got started pretty late, but once I got to know the patients and the disease, fell in love with it and pretty quickly decided I wanted to do it.
Good. Well, we're glad you did. We're glad you're here today. Let's take a look at that poll. We're really running on leukemia here. That C is our exclusive answer. How did they do?
Yes. So when you break it down to a specific subtype, acute lymphoblastic leukemia is the most common specific subtype of tumor in pediatrics. So with that method, it's breaking things down, I completely agree. Depending upon how you subtype different tumors, if you put all the brain and spinal cord tumors together, they may be the most common group. If you include a younger or older age group, up to 14 or up to 19 or up to 25, it changes, and hopefully I'll show that through a few slides as well. But certainly acute lymphoblastic leukemia is the most common type of cancer in kids.
All right. Well, thank you, and thank you to our audience for jumping right in and answering that. I do need to read the disclosure. This activity is planned and implemented under the sole supervision of Thomas Shea, MD, the course director in association with the Office of Continuing Professional Development, UNC-CPD. Thomas Shea, MD, consults with Spectrum Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, and Seattle Genetics. CPD staff have no financial relationships with commercial interests. The speaker, Thomas Alexander, MD, MPH, has no conflict of interest relevant to this presentation. All right, so meeting the unique needs of pediatric oncology patients. I'll turn the controls over to you.
Thank you.
There's the cursor as well, if you'd like to use that.
So thank you for taking the time to listen in. This is obviously quite a broad topic. I'll try to touch on an array of things that may be of interest to different groups. A little bit of a 10,000-foot view, and then hopefully as we go on, maybe a 8,000-foot or 5,000-foot view, just to give a feel for the kinds of diseases and patients and problems we are addressing in our group. So as far as just the outline, I want to spend the first 10 or 15 minutes describing the epidemiology of childhood cancer, specifically because it's quite different than what we see in adults. I want to list a few challenges and opportunities facing clinicians and the children and families that might be unique compared with adult patients. And then finally, I want to spend about 10 minutes with the more scientific and research focused topics, talking about what is the next step, what's been the last 2 years of research, and what's the next 10 years of research, and what are some of the goals specific to pediatric cancer. So I want to do this by way, those are my objectives, but I want to do this by way of introduction. So first I want to introduce the diseases that we focus on. Second, I want to introduce the cast of characters, and this goes beyond the patients and the doctors, obviously, with pediatric children, specifically child life specialists and teachers, other components of the team that you don't necessarily see as much in adults. So, as an example, yesterday was my full clinic day, and by 10 a.m. I had spent time speaking, of course, with nurses and nurse practitioners and pharmacists, but also had spoken with child life specialists, with the teachers that are embedded in our clinic, with an interpreter that's embedded in our clinic, radiation oncologists, surgeons, radiologists, and physical therapists. That's just what is involved in a multidisciplinary oncology clinic. But specifically with child life and teachers that really are important to what we do for kids. And I'll try to highlight that as we go through a few case examples. And then finally, I want to introduce you to some of the new developments, specifically precision medicine and immunotherapy. These are not completely unique at all to pediatric cancer, but I want to describe a couple ways which we are using it specifically. So objective number one, I want to introduce you to the diseases. For those of you who are not working in pediatric oncology, these names may be a little bit less familiar to you. So hopefully I can get you familiar with the names and teach you a little bit about what's different between children and adults. So the first thing, to just be very clear, pediatric and adult malignancies are different. That's what we know. That's not groundbreaking, but I think it is somewhat helpful to elucidate when you look at the groups of most common malignancies in adult men and adult women on the right. None of the top 5 malignancies in adult men or women make the list of any of the pediatric tumor subtypes. So if you look over at the pediatric tumor subtypes, the top right corner of this pie chart is the hematologic malignancies with the dashed yellow line, makes up about a third. The CNS malignancies, depending upon how you're classifying them and how you're getting the data, makes up about 25 to 30%. And then solid tumors, which are a wide array of things, make up the other third. But as you can see, it's very different than the group of tumors we're commonly seeing in adults. Also, and I'll say this a couple times during this slide, I want to give a little bit of perspective on the numbers. So in the United States this year, there will be between 14 and 15,000 new cases of pediatric cancer across the entire country. This year, there will be about 260,000 new diagnoses of breast cancer in this country. So you can understand the difficulty of studying some of these rare subtypes in pediatrics with the small numbers, which you're fortunate to have, but these small numbers, but it makes it a little bit of a challenge to move research forward. And another thing, even within the pediatric tumor subtypes, whether you're talking about 0 to 5 years old, 5 to 10, 10 to 18, the breakdown is quite different. So from the 0 to 14-year-old age group, leukemia is by far more common than lymphoma, and that flips pretty quickly as you get into the older teenage years where lymphoma is much more common. So to introduce a little bit more from the 10,000-foot view to the 8,000-foot view, I want to talk about some of these subgroups in a little bit more detail. So for those of you who don't spend time working with leukemia, just to make sure we're clear, there are 4 major subgroups of leukemia, and this is both adults and pediatrics. There's 2 subtypes of acute leukemia, AML, which is acute myeloid leukemia, and ALL, which is acute lymphoblastic leukemia. And then there are chronic leukemia subtypes, chronic myeloid and chronic lymphoid. So in children, here on the right, you'll see the epidemiology by age. In children, the peak incidence of ALL is between 2 and 4 years old. And you can see throughout childhood, but especially in that peak age group, ALL is much more common than AML in the childhood age group, from a ratio of about 5 to 1. If you flip this and look at adults, in expanding the age range, in adults, AML is much more common than ALL. If you look at the chronic leukemias, chronic myeloid leukemia is incredibly rare in pediatrics, and CLL is exceedingly rare, almost unheard of in pediatric age groups. So we are all dealing with both adult and pediatric oncologists with leukemia, but the typical pathology of what we're dealing with is quite different between these age groups. So even within, say, we're talking about just AML, even within that specific subtype, the genetic features and the biology in children is quite different than the genetic features in the biology in adults. So on the right-hand side, I show you a graph of different genetic features, and this is by age. So on the left-hand side, this is the group that has, the blue is a group that has a normal karyotype. And you can see in the young kids, that's very uncommon. As you move up in the age spectrum, the normal karyotype AML is more common. On the other hand, MLL rearranged with 11q23, a genetic abnormality, is very common in young kids, but becomes much less common as you increase in age. Just to make the point that even within a subtype, we are dealing with different biology in many cases than the adult colleagues. So while we try to take as much of the research data and as many of the ideas as we can from the adult colleagues, sometimes that doesn't translate down to kids in any way because the biology is so different. The other point on the left-hand side of the screen I just wanted to make is that in pediatrics, the pathology of tumors is intimately associated with the normal developmental biology. As cells are developing in the liver, in the kidney, in the bone marrow, what we see is biologic alterations in the form of mutations that block the differentiation and maturation of those cells, and additional mutations that allow continual cell survival. And so this is just the hematopoietic developmental tree, and it shows that anywhere in development we can acquire mutations that cause that cell to stop differentiating and cause that cell to continue to grow unchecked without undergoing cell death, and can lead to a different type of leukemia. Just wanted to emphasize the point that pediatric cancer in both leukemia and in many solid tumors is a disease of abnormal developmental biology where we acquire mutations that block the normal developmental processes. All right, one slide on brain tumor epidemiology, really to make the same point. But with brain tumors, there's 3 ways we understand prognosis and treatment. First, the first thing that's going to tell us a lot is where in the brain it is, the location. The second thing is histology, meaning what cell type the tumor looks like and how aggressive the tumor looks like. And then the last piece of information is the genomic information. And these three are not, they don't always go together. You can have genomic information across different histologies and locations, which further complicates how we classify and treat these tumors. On the right-hand side, just another pie chart to emphasize different age groups of very different biologies. I'm just showing the children here, but as you take this into adult biology and the epidemiology of adult brain tumors, it's again quite different. So moving over to our last big subtype, which is solid tumors outside of the brain, I wanted to make a similar point that throughout the age group, they're quite different. So the most common solid tumor that's outside of the brain that we see is something called neuroblastoma. It occurs most commonly in young children. It's very uncommon in the older teenage years, as you can see. Retinoblastoma is a less common tumor, but when we see it, it is usually in young children and not very often in the older teenagers. Similar with renal tumors, the most common of which is a Wilms tumor. Hepatic tumors are incredibly uncommon. When we see them, the most common is hepatoblastoma, and we usually see those in infants in the first few months of life. Bone tumors, specifically osteosarcoma and Ewing sarcoma, actually have an increased incidence in the teenage years. I'm not exactly sure we understand the biology of why that is, but less common in young kids, more common as kids are reaching adolescence. Sarcomas in the soft tissue is an incredibly heterogeneous group of tumors, the most common of which is rhabdomyosarcoma, and these can occur across the age spectrum of children. And then other tumors that begin to be classified as other epithelial cell neoplasms are less common in young kids and increase in incidence as you get older. So a little bit, I wanted to just make the point of the differences between adults and pediatrics, start to begin to say the names of these tumors, and if you're not familiar with them, and kind of march through that background of what we'll go into. I've stated this, but want to give perspective again, but to help us understand a little bit about what makes research so difficult in the pediatric oncology population is we designate orphan disease as a disease which affects less than 200,000 people in the United States. For perspective, as I mentioned, in breast cancer, it's estimated there'll be 266,000 diagnoses in 2018. If you add up all the types of pediatric cancer in all of the years of this century in the United States, you would not equal the number of breast cancer diagnoses this year. Again, emphasizing the challenge of understanding these tumors as we break them down further and further into their subgroups. So the last thing to just touch on, it is almost without fail, and this happened, I had 2 new patients in clinic yesterday, and both parents asked this exact question. They wanted to know why their child got this tumor. They wanted to know if they caused it based upon something they fed their child or gave their child or didn't do or did do for their child. So asking the why of a tumor in a childhood, which obviously makes no sense and is never just or fair in a child or anybody else. Wanting to know the why is an important thing. Unfortunately, we are doing a very good job at describing what is going on with the tumor. Not as good of a job as describing why the tumor occurred in the first place. With the explosion in DNA and RNA sequencing, we are realizing that more than we thought, there's a genetic predisposition for many of these tumors. So in a paper that came out of St. Jude and Washington University, they looked at germline predisposition across a wide array of tumors and found that they could confidently suggest that about 8.5% of patients had a germline genetic predisposition that they inherited or was found at birth that contributed to their development of their malignancy. That still leaves 90% where we can't answer the question of why in any way. Probably as we move forward and understand more about genetics and have more data, we'll be able to tease out more and more. Each year there's additional genes that we're understanding contribute to genetic predisposition. But right now that's where we are. We're just under 10%. We can say we think we understand a bit more about why. So my objective number 2, I want to introduce you to the cast of characters a little bit more as far as the patients and the people that surround these patients every day in our clinic. Introduce you to some of the challenges that are specific to the pediatric age range and help you understand just a little bit more about how we treat some of these tumors. So again, for those of you who don't work specifically within leukemia, a basic definition. Apologies to those of you who spend your whole life with leukemia. So leukemia comes from the word white, leuc, meaning white, emia in the blood, because at a high level of white blood cell count, it can truly turn the blood more of a white color. This image on the white was collected from a patient who came in with a very high white blood cell count. We used to commonly do a procedure where we would place IVs and run the patient's blood through a machine and separate out the white blood cells to minimize the complications of an extremely elevated white blood cell count, and that would be the result of it. As you can see, there can be pounds of tumor in leukemia. We don't think of it like we think of a huge abdominal mass where it's a huge mass, but this emphasizes the point that within leukemia there can be many pounds of tumors that the patient is dealing with. Hence, we have to be careful as we're getting rid of this tumor that we're not dealing with metabolic complications. But really, leukemia is a tumor of the bone marrow. I would like to rename it plenus medulla, but it doesn't roll off the tongue as well. But that is really what it is. It's a tumor of the bone marrow. You can see some histology on the lower right-hand side of the leukemic cells from patient bone marrow. So I want to introduce you to one of my patients. It would be great if I could show a video because that would be a lot more entertaining and a lot more enjoyable, but trying to be careful about patient identity and patient protection. But I want to introduce you to a patient of mine I'll call Diana. So she presented when she was 4 years old, typical leukemia presentation with fatigue, bruising, pallor, and a few days of fever. Life was busy for them, so this had been going on for a couple weeks before they came in. She came in, even though she had a very low hemoglobin, she actually was well appearing and even talkative and looked okay when she came in. Had a white blood cell count that was 44, which is elevated, but not at a very high level that's dangerous immediately. She had no disease in her spinal fluid, and her genetics were actually low risk. At day 8, we reassessed response to therapy, and then again at day 29, and she had a great response. So I'll highlight these things just to give you some idea of the things we look at to help us understand her disease category. With leukemia, all patients get treated for about 3 years, but we want to adjust therapy up or down based upon their risk. So each of these things I've highlighted reassured us that we are able to treat this patient with a lower intensity therapy. Her age being between 1 and 10 is low risk, white blood cell count lower than 50, and a good response to therapy and no disease in her spinal fluid. So by age 5, and she could explain the different types of white blood cells. She knew the difference between a lymphocyte and a neutrophil. She knew what the bone marrow did, all the types of cells it made. She knew what propofol, methotrexate, and 6-mercaptopurine are. She loved talking about asparaginase, just not getting it in her IV. And then we eventually had to give it to her with an injection, and she definitely didn't love that. But she liked to explain to everybody what it was. She would often explain to me and to the nurses what these medicines were doing. She knew how to do a bone marrow biopsy, at least in theory, and a lumbar puncture. She explained to me that the reason propofol was called propofol is because it makes you fall asleep. And I was confused at first, and I think after that she thought I wasn't a very intelligent doctor because I didn't know that was why it was called propofol. She's very intelligent, but all of that transition from being very sick in the hospital and being very sick with the first 2 months of therapy to understanding all these processes is very intentional. Our child life specialists were working with her starting from day 2 to help her understand. Our school teachers were in touch with her school to set up inpatient education and homebound teaching by day 2 of her being hospitalized. Our nurses and nurse practitioners, who obviously are used to working with children, worked with her to explain everything to her. Our anesthesiologist had her push the propofol when she was getting sedation, and then they finished up to help her fall asleep. But those are the kinds of people that surround these patients that we don't think about. In some ways, beyond the initial diagnosis and the complications, the nurse practitioners, physicians fade into the background while the rest of the team really supports patients like this to where they're not afraid to come to clinic anymore. They don't quite like it, but they're certainly not afraid, and that's important for their development. So I want to just spend 30 seconds going over 60 years and thousands of people's research to get to what we do for acute lymphoblastic leukemia in children. So in the 1950s, the first therapeutic attempts in this country were in Boston with Sidney Farber. And he and his colleagues decided that leukemia causes anemia like megaloblastic anemia. Megaloblastic anemia you can treat with folic acid. So let's try to treat leukemia with folic acid. Unfortunately, it made everything worse. It fed the leukemia cells faster, and the disease got worse. So probably with more thought than just let's try the opposite, but they then switched to an anti-folate medication called the precursor to methotrexate, which is what we use now. And they started to see responses where the leukemia started to slowly get less in terms of its how much it took over the bone marrow. They did not achieve any complete remissions or were not able to cure anybody in that decade. In the 1960s, they were able to achieve complete remissions, but nearly universally children relapsed, mostly in their CNS. In the 1970s, we began to occasionally see cures. This was with multi-agent chemotherapy and radiation therapy to prevent relapse in the brain. In the 80s, there was improved supportive care so we could give more intense therapy. Blood products became more available and safer, and so the cure rates were beginning to improve. In the 1990s, starting to get into more of cytogenetics, beginnings of understanding the genetics, and starting to see real cure rates in the 40s and 50%. 2000s, intrathecal chemotherapy came in as far as a replacement for radiation therapy, and this dramatically improved long-term outcomes. As you can imagine, giving radiation therapy to a child with leukemia when they're 1, 2, 3, and having a developing brain can lead to significant long-term morbidity. And then in this last decade, the decade we're currently really working on, still under the genomic revolution of being able to classify these leukemias down at a very detailed biological level and trying to figure out how we can incorporate that into treatment. So the treatment duration for ALL is about 3 years, depending upon the risk category and depending upon the sex of the patient. Overall survival now is above 90%, depending upon the subtype, the age, response to therapy. Higher risk patients who are not achieving those levels yet. As you can see on the right hand, this is an article that breaks down the survival curves based upon treatment era. And with each treatment era, we're making improvements, and hopefully we'll continue to move this up as far as overall survival, but also improve the toxicity by giving more targeted therapies. So common sites of relapse, just to try to continue to plug a few pieces of knowledge to maybe throw in your brain, is the common sites of relapse are the spinal fluid, testicles in males, and then of course the bone marrow. So at the bottom of these pages, I've tried to say on the left in the red box a few challenges, and on the right in the green box a few things we're trying to do to overcome these challenges. So as I've mentioned briefly, there are significant long-term side effects of the therapy we give. This is especially important for young kids who are still developing both their muscles and their bones and their brain and their nerves throughout their body. And I've listed the different side effects that can happen with different medications and different types of therapies. And we are understanding this in a much more nuanced way over the past 10 or 15 years, as many of these survivors are actually growing into young adulthood and late adulthood for the first time. So this is an article that came out last year looking at the burden of morbidity for patients with different diseases compared to controls. The black line at the bottom is a control population, and then the other lines show burden of different diseases based upon the type of pediatric cancer they had. As you can see, the red line is acute myeloid leukemia, and you can see the Hodgkin lymphoma is next to it as far as the number of toxicities that occur as the age increases. So that's an ongoing focus as we continue to adjust our therapy. All right, I spent a little bit more time on ALL than these other diseases because, as everybody who answered the question knows, ALL is the most common disease subtype that we see. I'll go through about 4 other types of diseases just to introduce them to you, but not quite in as much detail. So I'll talk to you about Stephanie, who actually was one of the first patients I met when I was training to be an oncologist. So she's presented as a 14-year-old. She presented with fever, fatigue, and what really brought her in was gum swelling. And the type of leukemia she has was AML M5, a monocytic myeloid leukemia. You can have significant infiltration in your gums of the leukemia. She had a white blood cell count of 305, significantly elevated. Hemoglobin and platelets were low. And it turned out she had a genetic feature called an MLL, or the new name is KMT2A translocation. She tolerated therapy incredibly well, had a complete remission. We debated whether to take her, offer her transplant or not, but with this translocation and some limited signs that was still there after therapy, we took her through, and she got a matched sibling donor transplant from her sister. This child was incredibly strong. She was one of the calming influences on the entire transplant ward. If she was sick, she would tell the nurses, "Don't worry, we'll take care of it." If we were worried about a fever, she would say, "It's okay, we'll get through it." Just one of the calm, peaceful personalities that I've ever encountered. So unfortunately, she relapsed 18 months after therapy. She got her back into remission and took her through to another transplant from her mom. But unfortunately, during that transplant, her body had been through a lot, and she died from treatment-related complications. So with AML, it's really important, like all of these are, that the siblings and parents are intimately involved in supporting their children and their brother or sister. It's especially important because in AML, many times we need to go to hematopoietic stem cell transplant. As you can see in this patient, she had a first transplant from her sister and then a second transplant from her mother. And so the family support is there, both emotionally going through this process, but also directly from a biological donor perspective. So AML, just a few bits about it. It's much less common than ALL. There's about 600 to 700 cases of AML diagnosed in children in the United States each year. What we hope for is about 5 months of intensive therapy. We treat these patients with the most maximally intensive chemotherapy that we can in an attempt to get rid of every bit of disease. The majority of time is spent in the hospital, and about 30 to 40% based upon different features will need, we recommend a hematopoietic stem cell transplant. So the outcomes are improving. Treatment-related mortality and morbidity is improving. In spite of that, about 35% of patients still have refractory disease or will relapse. So in the graphs on the right side, I show you one example of a trend in different trials. So these are relapse-free survival curves. So the one on the left is titled AML 97. These are trials done at St. Jude. So the relapse-free survival was about 45%. The blue curve, the blue volume are the patients who had a treatment-related mortality from therapy. The yellow is patients who relapsed, and the green are patients who had refractory disease. As you can see in the successor trial, the treatment-related mortality has improved significantly, and this has been shown again and again on multiple international trials. The relapse rate has improved slightly in the lower risk group, but we have been unable to make significant gains in reducing the rate of refractory disease or relapse in the high-risk subgroups. And the other thing that is one of my passions is, unfortunately, only about 20 or 25% of patients with relapse disease enroll on a clinical trial. Part of that is because these patients are spread throughout the whole country, and it's difficult to enroll them or open clinical trials at smaller institutions that may only see a couple of cases each year. So that's one thing that we need to work towards. We lament the fact that often we don't have enough cases in one place to run a research protocol that can generate good data, but we're not taking advantage of the opportunities we have. And so I hope that moving forward we'll do a better job getting these trial opportunities to more institutions. All right, the next disease I want to talk about briefly is Hodgkin lymphoma, to emphasize a little bit about the clinical researchers, both directly for the therapy but also for the long-term follow-up of these patients. So Christy is a patient who presented as a 14-year-old as well as my last patient. So she was 14. She had a painless lymph node on her neck. We ended up taking an X-ray and saw a mediastinal mass, as you can see. This is not her film, but a representative film. And then a CT scan, again showing a mediastinal mass. She underwent four months of outpatient chemotherapy, was never admitted, had a great response. And then the debate ensued about whether or not she should receive radiation therapy. The standard of care for her would have been radiation therapy. She did not get rid of all of her disease by CT criteria, though she did by her more functional imaging. So the standard of care would be radiation therapy. We know that women who receive radiation therapy have between a 20 and a 25% risk of developing breast cancer throughout their lifetime. So we were weighing that very heavily. We decided to forego radiation therapy for that reason. Radiation therapy, along with other therapies, can contribute to cardiac toxicity as well as breast cancer, which I mentioned. So again, I show another example of research going on to explain long-term outcomes for these populations. So I'll put your focus here on the bottom right-hand corner. So these are grade 3 to 5 cardiac toxicities in survivors, patients treated with Hodgkin lymphoma. Here are the patients who are controls, so patients that, in the general population, and here are patients treated with Hodgkin lymphoma, showing the dramatic increase in cardiac toxicity as a result of the radiation and the chemotherapy drug called anthracyclines. So that is an ongoing focus of clinical researchers to try to adjust the therapy we give without compromising the very good outcomes that we have for Hodgkin lymphoma. All right. The next one I want to touch base about is neuroblastoma. This is the most common solid tumor in children. So I want to introduce you to a patient of mine named Rachel. She presented as a 2-year-old female with a large abdominal mass. You can see over on the left side, again, not her film, but representative image. This is the abdominal mass above, if we could look at other images, above where her kidney is, attached to her adrenal gland. And just to be clear, neuroblastoma is not a brain tumor. A neuroblastoma is an abdominal tumor that grows out of the sympathetic nervous chain, but it's very commonly confused to be a brain tumor. So she was found to have regional spread, MICN amplification, and underwent lots of therapy with significant therapeutic complications, and she actually did not receive or achieve a complete remission and died of complications of her therapy. She, just to give you a perspective, and more this is indulging me, so sorry that I'm indulging myself to kind of remember about her, but she was an incredibly wild and wide open young girl, even with tubes and huge liver and things that were going on with her. She knew how to drain her own abdominal peritoneal drain. And every time I would go in the room, she'd hide behind the door and scream at me in a dinosaur voice and explain to me that it didn't mean that she was mad at me and I didn't need to be scared. And she would always call me Dr. Alessander. And it was just one of the sweetest things that kept me going through the day. And so these are the type of patients that we get to interact with as pediatric oncologists. And I just emphasize the nursing role in her care, partly because I mentioned she would say Dr. Alexander, but she didn't know my name until about 6 months into therapy, while she knew every nurse's name. And that's typical of our patients because that's where they spend most of their time. And she had to spend a lot of time in the hospital with the nurses, and so got to know them quite well. So a little bit about neuroblastoma. The risk category of neuroblastoma depends on the age, disease stage, and the biology. It's one of these very odd tumors that it can have dramatically different consequences in prognosis based upon the biology. Even in widely metastatic neuroblastoma with metastatic disease in the liver, metastatic disease in the skin, in a young age child, it can actually spontaneously resolve, or it can be treated with minimal therapy. On the other hand, in an older child with different biology, it is incredibly difficult to treat, even with all of our maximally intensive therapy. So as I mentioned, for low-risk therapy, in some cases, there is no therapy. You can observe these patients. On the other hand, for high-risk patients, we incorporate every therapeutic modality we have with chemotherapy, surgery, transplantation, radiation therapy, immunomodulatory therapy, differentiating agents, and still are only able to achieve a relapse-free survival of maybe 50% now. So this is the survival curves for neuroblastoma of low risk and intermediate risk in the 2000s, the first decade of this century. And for high-risk patients, it was about 40%. Newer therapy suggests that it may be closer to 50 to 60% now with our newer immunotherapy. But those results continue to come in. But even with those better results at 60%, we have a long way to go with these high-risk patients. So the last disease I want to touch base about is brain tumors, and I want to mention high-grade brain tumors. A patient of mine presented with a high-grade brain tumor was a 9-year-old, presented as he typically would with nausea and vomiting and disconjugate gaze. He received surgery, radiation, and intensive chemotherapy. And my patient was not Peyton Manning, in case you're wondering. Peyton Manning did not have a medulloblastoma. But my patient's favorite athlete that he wanted to talk about every day was Peyton Manning, to the point where I reached out to try to get Peyton Manning to come spend some time with him, but it was unsuccessful. This patient did very well and tolerated therapy incredibly well, but had significant morbidity from his surgery. And so more important than me throughout the second half of his therapy and any of his treating physicians was actually his physical therapist and occupational therapist, who really now mom follows up to see them and really not as much to see anybody else. So I want to mention 4 things that make brain tumors incredibly challenging in children and touch on a couple things that people are trying to do. So of course, when they're high grade, they're fast growing and infiltrative. That's not unique to children. Surgery is incredibly challenging because it's quite an important place in your body. A centimeter or millimeters make a difference, and surgeons can tell you much better than I can. Chemotherapy is challenging because it doesn't pass the blood-brain barrier as well as it can get to other places in your body. Radiation is incredibly challenging in children because of the increased toxicity in young brains compared to giving radiation to adults. So all of these things are challenges that people are working to overcome. I just highlight 2 things that are ongoing. The one on the right, there's a chemical actually that can localize specifically to tumors and help surgeons see better where the tumor is. Without this, and it shows up as green when you look at it under fluorescent light, so you can know where the tumor is and focus on that area instead of the surrounding normal tissue. The other thing that researchers are working very hard on is trying to make faithful models of brain tumors. So recapitulating the biology and recapitulating the treatment in mouse models and forming full tumor boards of understanding what we should do to understand these tumors better that are actually quite rare in children, but devastating, such that we've got to figure out a better way to study them so we can get better therapy into the patients. So I want to take the last 5 minutes before I get pushed off screen to discuss briefly, as much as I can, a couple of new frontiers and what we're trying to achieve in pediatrics for our patients. So I'm going to skip over most of the central dogma of biology, assume you know it, and if you don't, here it is. DNA is in all of our bodies, it is transcribed into RNA, and that is translated into proteins. So cancer is, for the most part, a result of abnormal DNA or abnormal RNA production. And so therefore we can look in these tumors what DNA is abnormal and try to target that process. So specifically for ALL, the explosion in DNA and RNA sequencing has led to an improved understanding of the diseases. So we understand that the biology in children is different than the biology in adults. In childhood standard risk leukemia, we see most commonly something called hyperdiploid or something called TEL-AML, or is a genetic change, which is uncommon in adults. There's was a large subgroup of other that we didn't understand. So the gray bar is the other, which is becoming smaller and smaller each couple of years as we understand the biology. One of the subtypes that we've become much more familiar with and started to understand over the last decade is a group called pH-like ALL. And it's driven by alterations in cell signaling. And in some ways, it's fortunate that that is a pathway that we think we can target with medications that are available. So this pH-like ALL on the right is a model of the different pathways that are altered. And these pathways can be inhibited with drugs that are currently available. And they're undergoing research trials. These used to be a higher risk subtype of ALL, and it currently still is, but we are optimistic that we can turn this around with these targeted therapies such that this is a standard risk or even lower risk therapy as we can specifically target the alteration of this disease. I wanted to mention a couple things about precision medicine and brain tumors. So brain tumors, as I mentioned before, is defined by location, histology, and genetics. So sometimes the genetics can tell us a target that we can use and the response can be profound. So this is a patient who had glioblastoma multiforme, which is a high-grade brain tumor that was surgically resected, but still, as you can see in the panel on the bottom left, there was active tumor there. It's a very difficult tumor to treat with cytotoxic therapy. They found an alteration in the BRAF gene that has been targeted in other diseases, and so for this patient, they targeted this alteration and saw a profound response, which is very surprising in this disease. So this is one example of a mutation that we can sometimes find with different prevalences in different tumor subtypes than to treat with our current therapy that's currently available. The most common place we see this mutation is in a brain tumor called pilocytic astrocytoma, and so there's much work going on to understand how to better treat this tumor. I show this to just mention one other type of fusion or one other type of alteration called an intract fusion, to emphasize one point I want to make, that these occur in 40%, which sounds like a big number, but that 40% is of non-brainstem high-grade gliomas in infants. So if you break down the subcategories, you can find tumors that represent targetable mutations, but you're chewing off less and less of the population, so studying them becomes more and more of a challenge. We need to do it, and we've got to figure out a way to do it, but to emphasize that challenge, it's smaller and smaller subgroups we're trying to go after. So the current way that the group called the Children's Oncology Group, which is a consortium of most of the pediatric cancer centers in this country, is called the Pediatric Match Trial. So what this group is doing is getting a tumor biopsy currently for patients with relapse disease, doing genetic sequencing to look for a target. If we find an actionable target, then we pick from a bin of a bunch of different trials with that target. And then we can treat those patients with specific therapies. So these are the current targets of alteration and therapies that are being looked at on this basket. One of the exciting things about this trial is you can continue to, as new therapies become available, add them in and look for new targets and continue to roll them into this network. As therapies show that they're not useful, you can take them off. This is a simple slide, but obviously thousands of hours of work coordinating all of this effort. Two things, there are caveats. One, only 10 to 20% of the patients will actually have an actionable alteration. So while this sounds great, there is still lots and lots of challenges to overcome. And right now, these are being treated by single agents for the most part, but we know that we're going to need to incorporate multi-agent therapy for the large majority of these targetable lesions to actually achieve a cure. So challenges to be overcome, but that's how we're starting to address it in the pediatric oncology group. So I'm going to skip through the immunotherapy because we're out of time, and the immunotherapy, I think we have a lot of probably specific lectures to go over that. But in summary, I hope you saw through all of my mini pie charts and tried to say it over and over. The biology, the patients, and the therapeutic requirements for children are different than adults, and even different age ranges in children, from infants to toddlers to teenagers, they're quite different. It clearly takes a village, and if you are in direct healthcare provision, you know that. But I think you don't understand the degree of it unless you're in a pediatric clinic, where within 20 yards I can reach a teacher, a child life specialist, an interpreter, nurse practitioner, pharmacist, to try to help get what we need for that child. And then finally, precision medicine and immunotherapy are approaches that are providing lots of promise and actually being implemented directly for our patients, but there are lots of challenges, so we are not there yet and have a lot of work to do to know how to best implement all of this new exciting research data. So thank you so much for taking the time. Of course, I'd love to have a back and forth if anybody has questions.
All right, Dr. Alexander, thank you so much. This has been great. Let me go ahead and move over to, there are a couple of slides with references here, and then what we'd like to encourage you to do is go ahead and submit your questions. Remember, you text 22333 with the letters UNCCN. You get a message back, join, if you didn't already do that, and then you can go ahead and fire off your questions to Dr. Alexander, and we'll take those as quickly as we get those. First, a comment while we're waiting. I was able to see the video of Diana, and I just loved the way in which she felt so empowered to really know so much about her disease, and that was really impressive.
Yeah, and it's not unique. Yeah, her family is wonderful and helps along, but that's not unique. We have most of our, by the time they're 5 and 6 year old, are explaining everything they're going through.
That's great. That seems really powerful. I've got to imagine that's got a very positive impact. I did wonder, if you would tell us a little bit more about, as the pediatric patient grows up and goes through his or her life, what are some of the ways in which that patient in remission can be supported, fertility issues, long-term effects of chemotherapy, et cetera? What are some of their needs throughout the course of their lives?
Right. It's a huge challenge.
Yeah.
We I think, a pretty good job in the first couple years after, as they're still connected to a pediatric oncology clinic, but then most of them get lost. As you can imagine, as they move to college, move somewhere else, their in general internist is not as comfortable, really, nor should they be, always dealing with the issues. But yes, fertility is a challenge. Intellectual impairments, even if they're subtle, attention deficits, depending upon what therapy they received. They need screening, echocardiograms to look at their cardiac function. So there's a lot that needs to be done. We are debating as a community whether it's better to do that in a multidisciplinary clinic where you have access to all that, or whether we need to ship that out to the generalist to be able to take care of that. And there's differing views on what's better.
Sure. Thank you. Let's see. We do have some questions coming in. If you'd please expand on mixed phenotype research.
Right. So mixed phenotype is a rare subtype of leukemia that has features of both ALL and AML. And as a couple years ago, you'd ask anybody how to treat that. Half people would say you treat it with AML-based therapy, half would say ALL-based therapy, and they're dramatically different therapies as far as your strategy. What we are learning is that for subtypes that look like a B-ALL and an AML, a lot of the genomic features really line up with what we see in B-ALL, so a lymphoid approach makes a lot of sense. Other research has come out suggesting clinically that ALL-type therapy also makes sense for that group of patients. Patients with a phenotype of T-ALL and AML are genomically and biologically different, and they're really more in a spectrum between ALL and AML, so the best therapy for them remains a little bit less clear.
All right, thank you. Would you transplant several times if the child kept going into CR, or is there a time you'd stop to avoid the side effects that can affect their future? We'd have to infer from there, but
yeah, it is a question that comes up often. It depends. It's less about their long-term toxicity. Usually, it's more about their short-term toxicity. If a patient's been through 2 or 3 transplants, they usually have organ dysfunction that puts them at significant risk for mortality going through that transplant. We've all heard about, and many of us in medicine are seeing the patient who got 3 or 4 transplants, which is great for that patient. It makes it complicated in some ways for patients that have been through 2 transplants, and they've heard about that and trying to reconcile that possibility with what we see is that we know someone going through a 3rd transplant, the mortality risk is so high. So it's a question that comes up, and there's not a direct answer. But that's really, I think, what we are weighing more than the long-term toxicity, which is certainly there.
All right, thank you. And with just a minute or 2 left here, the CAR T cell use at UNC?
Yes, there's a huge effort for CAR T cells here. We've got 2 investigators that are leading large labs. So there is a CAR T cell with CD30, which is directed against Hodgkin lymphoma or ALCL primarily, that is underway in both adults and pediatrics. There's a CAR T cell with CD19 that is underway in adults, will open in pediatrics soon after that. There are CAR T cells in development for neuroblastoma, for which a protocol is written. They're in development for many other types of tumors, including certain brain tumors and AML. But underway, we have them for Hodgkin lymphoma, ALCL, and CD19 positive B-cell malignancies.
All right, thank you so much. Let me just go through a few things before you leave us today. Just to let you know that we want to say thank you to you as an audience for being here. Of course, this has been recorded and will be available both if you just want to view the video or if you want to go onto our learning portal and or maybe refer this to a colleague who can go there and view after the fact and receive credit for watching the lecture through our learning portal. We want to thank the North Carolina General Assembly for their generous support of the UCRF, or University Cancer Research Fund. We want to thank UNC Lineberger. We want to call out Mary King, Veneranda Obore, and John Powell for all the hard work they do to make this and every lecture possible. Coming up, we've got on April 11th, RN and Allied Health Lecture, the 7th vital sign identifying malnutrition, and that's with Meredith Moyers. Then on April 25th, Medical and Surgical Oncology Lecture, GU Cancers, Best of ASCO, with Dr. Matt Malowski. And on April 27th, our Community Lunch and Learn Hospice Care and Caring for the Dying and Their Family with Nicole Sartor. So we hope you'll be able to join us for all of those, unccn.org. You can find out lots about that and all sorts of other things going on. Please be sure to provide feedback to us after this lecture. We really appreciate your being here. And just a reminder, we'll be switching to a Zoom format. We've been using WebEx and GoToWebinar for previous lectures for the last several months. We'll switch up to Zoom. We'll send out more information about that. We think you'll find that an easy and beneficial transition. So we'll look forward to seeing you either on your video conferencing unit, on MediaSite, or in Zoom at our next and all future lectures that are planned. Thank you so much. Have a great afternoon. Thank you, Dr. Alexander.
Thank you for having me.